Hello, my name is Dr. Dewan S. Raja. Today I will discuss about basal cell carcinoma. Basal cell carcinoma is the most common malignant skin tumor and the most frequent cancer in human. It arises from the stratum basal of the epidermis. Epidermis has multiple layers. The basal layer is at the base, then we have the stratum basal, then stratum spinosum, stratum granulosum, then stratum corneum. So basal cell carcinoma arises from the stratum basal of the epidermis or hair follicles. Although locally invasive and destructive, basal cell carcinoma rarely metastasizes. Epidemiology: around 70 to 80% of non-melanoma skin cancers, most common in fair-skinned individuals, especially Fitzpatrick skin type 1, type 2. Peak incidence more than 50 years, but increasingly seen in younger patients with high ultraviolet exposure. Male predominance, although site-specific, women may have more truncal lesion. So in the head and neck, it is mostly in the male, but in female there may be vulvar basal cell carcinoma, although that part is not exposed to sun. Risk factor: ultraviolet radiation, chronic sun exposure, strongest risk factor. Ionizing radiation, arsenic exposure. Old time, there was a treatment for psoriasis by arsenic that used to lead to basal cell carcinoma. Immunosuppression post-transplant HIV. Also, it is found in a patient with history of ankylosing spondylitis or a patient with ringworm on the head. They have more chance to get basal cell carcinoma. Genetic syndrome: Gorlin-Goltz syndrome, nevoid basal cell carcinoma syndrome, PTCH1 gene mutation, multiple basal cell carcinoma at a young age. In this syndrome, we'll get multiple basal cell carcinoma. It may be associated with also xeroderma pigmentosum. So, risk factors: mostly ultraviolet radiation, but not necessarily always. As for example, in female, basal cell carcinoma of the vulva. In that condition, ultraviolet radiation is not a factor. People with ankylosing spondylitis or extensive ringworm in the head and neck may have more possibility to develop basal cell carcinoma. Clinical features: usually develops on sun-exposed areas, face, nose, periorbital, perioral, ears, scalp, upper trunk. Nodular basal cell carcinoma most common, pearly papule or nodule with telangiectatic surface vessels, may ulcerate, lead to rodent ulcer with rolled edges. Superficial basal cell carcinoma, erythematous scaly patch on trunk, mimicking eczema or psoriasis. Pigmented basal cell carcinoma contain melanin, may resemble melanoma. Morphiaform sclerosing basal cell carcinoma indurated, scar-like lesion with poorly defined margin, most aggressive subtype. So morphiaform sclerosing basal cell carcinoma, that is most aggressive subtype. Okay, if you look at the images, this is from Me Skin, from Google Images, we can find out that types: nodular basal cell carcinoma, superficial basal cell carcinoma, pigmented basal cell carcinoma, basosquamous basal cell carcinoma, morphic basal cell carcinoma. This is very aggressive among them. Okay, these are images of the basal cell carcinoma or rodent ulcer. Here, all of them are nodular basal cell carcinoma. So, how the basal cell carcinoma behaves? This is locally invasive and destructive. May invade cartilage, bone, and vital structure, that is orbit. So, the patient may be diagnosed by an optometrist or ophthalmologist if it happened around the orbit, usually. Extremely rare metastasis, less than 0.1%. How can you diagnose basal cell carcinoma? Clinical suspicion confirmed with skin biopsy, punch, shave, or excision biopsy, dermoscopy, herborizing vessels, ulceration, shiny pearly borders. These are the diagnostic way identified by dermoscopy and skin biopsy. Histopathology of basal cell carcinoma. This is more or less schematic. This is the basal cell layer, that is the stratum basal. From there we have this, the basal cell carcinoma. We'll get basaloid tumor arising from the epidermis, from the basal cell of the epidermis. Nest of basaloid cells with scant cytoplasm and elongated hyperchromatic nuclei here. Peripheral palisading, that means like a fence. Okay, lot of nucleus cell here. Okay, that make a fence-like appearance. Peripheral palisading, myxoid stroma in between the palisades. Okay, and peritumoral clefting here. Here we are seeing basal cell carcinoma from another resource, Medscape reference. This is the basal cell carcinoma. This arises from the stratum basal or the basal layer of the epidermis of the skin. Treatment: surgical excision with histological margin. Control is gold standard, but Mohs micrographic surgery preferred for high risk or recurrent tumor, especially in cosmetically sensitive areas like nose, eyelids. Other option: curetage and electrodesiccation for small superficial lesions, cryotherapy, topical therapy, imiquimod 5-FU for superficial basal cell carcinoma, photodynamic therapy, advanced metastatic basal cell carcinoma, Hedgehog pathway inhibitor, vismodegib, sonidegib. In case of advanced metastatic basal cell carcinoma, we'll give hedgehog pathway inhibitors. Prognosis excellent with early diagnosis and treatment. Local recurrence risk high with infiltrative morphiform histology, periocular, nasal, ear, and lip locations. And prognosis is bad, okay, or recurrence rate is high also in incomplete excision. That's all about the basal cell carcinoma. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.